Hello and welcome to our presentation on the 2025 Medicare Therapy Assistance. My name is Zachary Edgar, and this presentation is brought to you by Therapy Comply. Therapy Comply is a membership-based compliance firm dedicated to physical, occupational, and speech therapy practices. Members can access our wide selection of guides and sample policies on federal and state law, along with our guides and updates on Medicare, Medicaid, TRICARE, and a large selection of private payers. We offer our members billing support such as policy and claims reviews, assistance with appeals and prior authorization, and keeping up to date with policy changes for no additional cost. Members can email us at any time with any compliance or billing questions or arrange a phone call. We also offer comprehensive services like compliance and billing audits, custom policies and procedures, and credentialing. Check it out at therapycomply.com. This presentation is for informational purposes only. None of the material is intended as legal advice. Statutes and regulations are all subject to change. Starting on January 1st, 2025, Medicare will allow PTAs and OTAs to be supervised under general supervision. That means that PTs and OTs can be off-site but available through telecommunications when assistants are treating patients. And the rule defers to your respective state laws and supervision. 44 states allow PTs to be off-site and 49 states allow OTs to be off-site when an assistant is treating a patient. The reason Medicare gives are that assistants in institutional settings are already allowed to be under general supervision, state laws that mostly allow for off-site supervision, shortages of PTs and OTs across the country, increased access for patients, and estimated Medicare savings of $271 million over 10 years, and that's due to the 85% cut for assistant services. Some important points: the therapist must still meet the progress report requirement that they treat a patient with at least one unit of therapy every 10 treatment visits, and you still need to follow your state law and make sure you meet the requirements for periodic visits, any requirements for supervision logs, and other communication requirements the state statutes and regulations may have. Medicare will continue to allow for general supervision of therapy assistance by physical therapy and occupational therapy practices for remote therapeutic monitoring services. And this again means that general supervision means that a therapist can be off-site, but it must be available through telecommunications. And in facility settings, will still require general supervision, and there still needs to be periodic visits are required, for example, every 30 days in an outpatient rehab facility. So CQ and CO modifiers still must be used, and these are increasingly required by a lot of other payers such as TRICARE and and more private payers, so this is important information. The CQ modifier is used for physical therapy assistance. The CO modifier is used for occupational therapy assistance. Other modifiers such as GP and GO and KX modifier are still required. The CQ modifier must be reported when the GP therapy modifier and the CO modifier with the GO therapy modifier. Claims with modifiers not so paired will be rejected and returned, and there's still going to be the 15% payment reduction for assistant services that started in 2022, and the cut does not apply to the 20% patient coinsurance portion, so it turns out to be a net 12% cut. So the modifier is required when the assistant furnishes all of the minutes of services independent of the respective PT or OT. The assistant furnishes a portion of the services or a unit of service separately from the part that is furnished by the therapist, such that the minutes for that portion of a service or unit furnished by the assistant exceed 10% of the total minutes for the service or unit of service. The modifiers are not required when the therapist provides services for the entire time and when the therapist is involved for the entire duration of the service and the assistant provides skilled therapy alongside the therapist, then you don't need to use these modifiers. So in the first example, the assistant provides 10 minutes of 97110 and the therapist provides 5 minutes of 97110, so a total of 15 minutes for one unit. And you're going to bill that one unit with the CQ modifier because the assistant provided 8 minutes or more and the therapist provided less than 8 minutes. The de minimis standard applies in that case. In example number 2, the assistant provides 5 minutes of 97110, and the PT provides 6 minutes of 97110, so 11 minutes, which is one 15-minute unit. And you're going to bill 1 unit of 97110 with the CQ modifier because the assistant and therapist both provided less than 8 minutes. In the case, the PT provided 6 minutes and the PTA furnished 5 minutes independent of each other, and that de minimis standard applies. In example 3, the assistant provides 5 minutes of 97110 and the therapist provides 30 minutes of 97110. 35 minutes or 2 units. You're going to bill 2 units of 97110 without the CO modifier because the OT furnished 2 complete 15-minute units of therapeutic exercise, and you're going to record the 5 minutes of service by the OTA with the total time for the treatment session, and even though that time is not billable. In example 3, the assistant spends 22 minutes of 97110 and the therapist spends 23 minutes of 97110, so 45 minutes or 3 units. You're going to bill 1 unit of 97110 with the CQ modifier because the PTA provided a full unit of service, and 2 units without the CQ modifier because 1 unit for the full 15 minutes provided by the PT and 1 unit because the 8-minute rule is applied to the final unit. So for different services, the rule changes. So when the assistant provides 11 minutes of 97535 and the OT spends 11 minutes of 97530, you have 1 unit. The de minimis standard does not apply when different services are provided by the OT and the OTA. Since the 2 different services were furnished for an equal amount of number of units, or the tiebreaker scenario, you can bill either 1 unit of 97533 with 97530 without the CO modifier, or 1 unit of 97535 with the CO modifier. So for untimed codes like group therapy, the rule is different. So the OTA spends 20 minutes of 97150 independent of the OT, and the OT spends another 20 minutes of 97150 independent of the OTA. So total 40 minutes of group therapy, which is just 1 unit. CPT code 97150 is billed with a CO modifier because the OTA's minutes represent 50% of the total time for the group therapy services. Split units. In cases where there's 1 final 15-minute unit left to bill, the 8-minute rule is applied when the therapist furnishes 8 or more minutes for the Medicare billing requirement for the final 15-minute service unit. The final unit is billed without the CQ-CO modifier because the therapist provided enough minutes on their own, more than half, to report the service. When there are 2 units of the same service remaining to be billed, and the therapist and the assistant each furnish between 9 and 14 minutes of the 15-minute time service, where the total time of therapy services in combination is at least 23 but no more than 28 minutes, 1 unit of service is billed with the modifier, and, one unit is billed without the modifier. Thank you for watching, and please visit the website for a lot more comprehensive information on physical, occupational, and speech therapy compliance and billing. Please like and subscribe. We'll be adding many more videos soon.